Welcome to Critical Matters, a sound critical care podcast covering a broad range of topics related to the practice of intensive care medicine. And now, your host, Dr. Sergio Zanotti.
Welcome to another episode of Critical Matters, the Sound Critical Care podcast. Today we have a very interesting topic that has been a topic of controversy and discussion for several years now in our field, which is the use of corticosteroids in critical illness. It's a great pleasure to have as our guest Dr. Steven Pastores, who is a critical care medicine physician, is director of critical care medicine fellowship, training and research programs at Memorial Sloan Kettering Cancer Center in New York, and also a professor of medicine and anesthesiology and medicine at Weill Cornell Medical College. Dr. Pastores is actively involved in critical care medicine at a national and international level. He serves as a member of the Board of Regents of the Society of Critical Care Medicine and is also a member of several editorial boards, including Chest Journal, Critical Care Medicine, and the Journal of Critical Care. Dr. Pastores was the recipient of the Distinguished Service Award and the Safar Global Partner Award from the Society of Critical Care Medicine for exceptional leadership contributions to the vision and mission of the Society. It's a great pleasure to introduce Dr. Pastores. Steve, welcome to Critical Matters.
Thank you, Sergio. It's a pleasure.
So as I said, today we're going to talk about a topic that seems to be on a pendulum in critical care, which is corticosteroids and critical illness. And it seems that every 10 years we have some new information or new approaches. And as we move forward, we seem to be becoming much more specific and I think educated in what really this means for our critical ill patients. And I think it's a timely discussion since, Steve, you have co-chaired a recent guideline from the Society of Critical Care Medicine and the European Society of Intensive Care Medicine that has just been published. I understand it, Critical Care Medicine and Intensive Care Medicine as a two-part document talking about CIRCI. So maybe we should start with, what is CIRCI?
So CIRCI stands for Critical Illness Related Corticosteroid Insufficiency. It's a term and an acronym that we came up with back in the 2000 to 2007 period when we were charged to come up with the first set of guidelines on the use of corticosteroids in critically ill. At that time, our knowledge and understanding of critical illness-related corticosteroid insufficiency was rather very basic and somewhat lacking in granularity. We envisioned at that time, and most clinicians in practice thought that what we were referring to largely was a syndrome akin to relative adrenal insufficiency, that there was some impairment of the hypothalamic pituitary adrenal axis that was pronounced in critically ill patients, and that maybe there was some resistance of the tissues to the action of glucocorticoids. So that was what our understanding was at the time, and that corticosteroids were going to be used, and if it were in conditions associated with CIRCI, it would be not so much necessarily a replacement in situations where it was felt to be deficient, but rather trying to overcome perhaps some of that corticosteroid resistance problem. But it really was fundamentally somewhat of a very basic understanding at the time. Fast forward 10 years later, there has been a greater understanding of the syndrome. And really one of the other pillars of this syndrome is that in addition to the impairment of the HPA axis in critical illness and the tissue resistance to corticosteroids, there's really an alteration in the metabolism of cortisol that's largely been dictated by the mechanisms that break down cortisol in the liver and the kidney. And so it's the combination of these three factors right now that we think is responsible for why this syndrome develops in more specific conditions like sepsis, ARDS, but may also be evident in other critical care syndromes as well.
And I think, like you mentioned, this has been an evolution of our understanding. We started this maybe in the 1980s by trying to modulate inflammation and sepsis with high-dose steroids, and that has evolved into, it seems like every decade, a different iteration of our understanding. And now, coming on 2018, 10 years after your previous guidelines, we're now talking of a syndrome related to critical illness in general that has many causes, as you mentioned, that we're much more aware now than we were before. Quick question regarding symptoms. I mean, I think it's always good to remember that we're clinicians and start with symptoms and signs. It seems that a lot of the potential signs and symptoms related to critical illness related corticosteroid insufficiency, or CIRCI, are very nonspecific. Are there any that you want to comment that might be of more use at the bedside for our intensivist?
So most of the studies examining the condition of CIRCI have largely focused in sepsis and septic shock and in the acute respiratory distress syndrome, or ARDS. And many of the signs and symptoms of these conditions can really have very nonspecific manifestations. I think the classic manifestations that we would think about at the bedside are the conditions where someone is hypotensive, is not responding appropriately to fluid therapy, and they additionally require a vasoactive or vasopressor agent. That would be like one classic manifestation where this syndrome might be thought about, which is what we normally see in patients who go into septic shock. The other presenting signs, as I mentioned, like fever, electrolyte imbalances, generally are common enough in other settings. And so it's sometimes very hard to distinguish what truly is CIRCI to other conditions that may be related to not necessarily infectious conditions, but more metabolic or hormonal abnormalities, like classic adrenal insufficiency, for example, would be very different in terms of how we would compare that to the more traditional syndromes that we see in ICU patients like sepsis, ARDS, and even in patients with major trauma.
Absolutely, and I think that as a take-home message for the listeners, really the cardiovascular signs of hypotension, refractory to fluid, decreased sensitivity to catecholamines in the context of a high cardiac index clearly seem to be something that we see often with our septic shock patients who might have manifestations of CIRCI. Steve, what about diagnostic? And I know that there's been a lot of debate, and I haven't reviewed the literature lately in terms of what's the best diagnostic tool other than clinical intuition for trying to establish a diagnosis. I know that there's a lot of controversy in this area, and perhaps not necessarily a definitive answer. But what is the guidance from the group that you co-chaired in the guidelines?
So this was a very challenging question for us, and in fact, we ended up being unable to make a very clear-cut recommendation on what the best single diagnostic test should be to identify this syndrome. Classically, we use the ACTH stimulation test, and we use the 250 microgram test, where we get a basal level of cortisol. We then inject intravenously 250 micrograms of cosintropin or synthetic ACTH, and then we check the increment in the cortisol level from baseline at 30 minutes and at 60 minutes. And we've been classically taught from other studies, including the study by my co-chair, Jalali Anand, that the failure to increase from basal at 30 and 60 minutes, or what we call the delta cortisol, greater than 9, and if someone did not get a response greater than 9, then they would be deemed a non-responder, and that would be something that would be seen commonly in patients with CIRCI. There are many questions surrounding the ability of that test to actually really distinguish patients with or without the syndrome. The question about the 250 dose of ACTH being supraphysiologic. Other studies have used 1 microgram, and there have been different sensitivity and specificity rates to either of these two tests. And so other types of tests have been envisioned, including a random cortisol, including getting salivary cortisol even has come up, and other types of testing to try to get at it. But we were particularly challenged with the question of what's the single best test, and basically we were unable to make a recommendation as to whether the delta cortisol or the random plasma cortisol would actually be truly diagnostic of this syndrome. We felt that most clinicians still go and use the 250 microgram synthetic ACTH dose and looking for that less than 9 delta cortisol change at 30 and 60 minutes. Others we know like to use the random plasma cortisol, knowing that in critically ill patients you lose that diurnal variation in cortisol levels, so it really doesn't matter what time of the day you're getting a random cortisol. But in reviewing the studies for the task force guideline, we simply could not get consensus, meaning 80% of the task force members could not agree on making a single recommendation on which test to use for this diagnosis. So that's really as far as we could go regarding that question.
So from the point of view of the task force and the available evidence right now, either an ACTH stim with cosentropin at 250 or a random serum total cortisol in a critically ill patient, for example, somebody who's requiring vasopressor support that is below 10, would be potential tests that we could use, but it's hard to really recommend one over the other. Would that be the correct interpretation?
Yes, and we felt that in many patients, particularly those who are already in septic shock requiring vasopressors, the decision to use corticosteroids should not rely on having to do this test as a requisite when deciding to use corticosteroid therapy in patients with refractory septic shock who are already adequately fluid repleted and are continuing to require vasopressor therapy to maintain an acceptable blood pressure, in this case a mean arterial pressure of at least 65 millimeters of mercury or greater.
Excellent. I think that's a very important point, that these are tests that are available that have their strengths and limitations, but in the context of specific populations that we'll dive in a little bit, it might not be like you said, a prerequisite to initiate therapy. So we'll get there. One more question regarding diagnostic testing. So I remember that around the time that the Cortico study was published, there was a lot of discussion about plasma total versus free cortisol. Any comments on that, Steve?
Yes. So there was a very nice study that was published in the New England Journal of Medicine in 2004 that looked at plasma-free cortisol being more helpful than total cortisol, realizing that free cortisol really is what we call the bioactive form of cortisol, and critically ill patients are known to have low serum concentrations of an important protein called cortisol binding globulin, and most patients have low albumins. And so in patients with very low levels of cortisol binding proteins, the use of the serum total cortisol therefore may not predict free cortisol, which is really what you want to measure. And so that particular study raised some concern about whether we should be switching and start using free cortisol rather than total cortisol. The problem with measuring free cortisol levels, however, is that the techniques to do this test are, as we say in the paper, are rather cumbersome and not available in most laboratories at many medical centers, and the turnaround time is not fast enough to get this test available immediately at the bedside. And so as a result of that, we suggested against using free cortisol, and instead if you favor the use of plasma total cortisol for the diagnosis of CIRCI. Although, as you will note, Sergio, most of the recommendations throughout our guideline really are conditional recommendations, or what used to be called weak recommendations, is using the strong versus weak terminology. And that is what it means, therefore, is in the settings where we have given a conditional recommendation, we are really letting the clinicians know at the bedside that based on the most current evidence from the literature, that these conditional recommendations, we're leaving it up to the judgment of the clinicians based on their individualized decision-making for caring for these patients, that the evidence might be weak in supporting this recommendation, and we quantify that level of evidence from low to high, depending on the availability of randomized controlled trials and specific study populations. So for the question on free cortisol versus total cortisol, the evidence for that was very low, and so the recommendation could only be made as conditional.
Okay, and I think that it might be worth taking a little bit of a sidebar just to quickly talk about the guidelines, which really follow what I think most of our Society of Critical Care Medicine guidelines and similar guidelines are using, is the grade system in terms of evaluating the available evidence and making recommendations. And like you mentioned, Steve, there's two categories of recommendations: strong versus conditional, which are usually phrased as we recommend versus we suggest. Could you give us a little bit of an idea to the audience? We recommend, or a strong recommendation, what does it mean for patients and what does it mean for clinicians?
So there are many factors that are considered. We try to make these guidelines to be truly applicable at the bedside by looking at it from the level of many factors. And among the many factors besides the evidence was basically how applicable these recommendations were going to be, depending on the values and preferences, not only for the clinicians, but also more importantly for the patients, and what the cost implications might be. So the recommendations from grade, for example, really factor in not only the quality of the evidence, balancing the risk and benefits of the treatment, the values and preferences as applicable for the patient, and the cost of the interventions. And so where we use the phrase we recommend, we use that phrase for recommendations that are strong, and we suggest for recommendations that we would call conditional, or synonymous to the older term, weak recommendations, and making the clinicians and the bedside providers understand that for conditional recommendations where we only suggest, we are not prescribing a specific, practice intervention that you should be doing, but rather, in fact, cautioning and making sure that you're using that recommendation in a situation where you feel is clinically appropriate, balancing the risks and benefits of the corticosteroid intervention to the quality of the evidence, and of course to the cost implications.
Excellent. I think that's a very important point. And also, like you mentioned, the spirit of the guidelines is to serve as a tool based on a review of the literature by experts, and not necessarily as a mandate. And especially when we don't have enough evidence, I think that clinicians need to understand how that decision making has to be applied at the bedside at a very individual level for each patient. So I think that we can maybe jump in and talk a little bit more about the disease processes and where we stand today in terms of treating these patients with corticosteroids. And you had mentioned earlier that the three great groups of patients, or big groups of patients in critical care, where we think about CIRCI and we think about treatment, with corticosteroids includes sepsis and septic shock, ARDS, and trauma. So why don't we start with sepsis and septic shock? Um, Tell us where we stand today, Steve, in terms of treating patients who have severe sepsis but are not in shock with corticosteroids.
So we felt very strongly that for patients who have sepsis or even severe sepsis, but not in shock, that corticosteroids are not to be recommended, and that corticosteroid use should only be recommended in patients who are in septic shock that is not responsive to fluid and requiring moderate to high dose vasopressor therapy. We quantified the dose of moderate to high dose as anything that would require 0.1 micrograms per kilogram of norepinephrine or its equivalent. I would caution though that, and I know I've been asked this a few times, that, depending on the patient's body weight, 0.1 micrograms per kilogram may not be truly considered to be a moderate dose. Somebody weighs 100 kilos, for example, well, that might only translate to 10 mics, and some might argue, well, maybe that's not even a moderate dose. But I think we leave that certainly for clinicians, but I think most clinicians will see that anything that's above 10 mics is in the moderate zone, and anything over 20 mics of norepinephrine per minute would be considered to be a high dose range. So anybody that is fluid repleted and continues to require moderately high vasopressor requirement and is in septic shock, we felt we could make a recommendation there. It is a conditional recommendation. We quantified the evidence there as still low. There are two large trials that are going to have new information for us. One is the trial called the adrenal trial, which is going to be published hopefully soon, and that's from the Australia-New Zealand group. And the other is the approach trial of corticosteroids alongside activated protein C. This was done before protein C got dropped, but the trial continued without the activated protein C arm. That's Jalali Anain's trial in France. And these two studies will hopefully inform further recommendations. And so depending on how those results come out, we are anticipating the need to update these guidelines perhaps in the next few months, again, depending on how those studies are resulted in the literature.
So it sounds like we'll have to have you back again to give us an update on those exciting studies. But just to summarize and what you talked about in treating severe sepsis and septic shock. So in patients who are not requiring vasopressors, there's probably no role to think about CIRCI, test about CIRCI, or treat them in general terms. And in patients who, I'm sorry, go ahead. You want to comment on that, Steve? Go ahead.
No, you're good. Yes. Mm-hmm.
And in patients who are in septic shock and are requiring vasopressors at a moderate to high dose, and you've defined that based on the amount of norepinephrine, we probably, as you had discussed earlier, would consider starting treatment without necessarily having to go through the diagnostic testing. Is that correct?
That is correct. We felt strongly, even though we graded the evidence as moderate and made a conditional recommendation against the use of corticosteroids in adult patients with sepsis who are not in shock. And we also suggested that steroids only be used in patients who are in septic shock that's not responsive to fluid and moderate to high dose vasopressor therapy.
So let's dive in a little bit in terms of the specifics of your practice based on, obviously you have a tremendous understanding of the literature and of the current guidelines. If you had a patient who you were treating, who's, like you said, fluid resuscitated, who requires high doses of of vasopressor, let's say even more than one vasopressor, how would you treat that patient for CIRCI?
So, I mean, normally a patient that's requiring high dose of one pressor and a second pressor is being introduced. My usual practice, Sergio, is when I see the norepinephrine dose escalating to about 15 mics per minute or greater, I already consider starting a second agent. And that second agent is more commonly vasopressin, but certainly epinephrine can be used instead of vasopressin with the goal of trying to reduce the dose of norepinephrine, or at least to try to come off norepinephrine faster. In those patients that are on a single dose of high dose vasopressors and or are in need of two vasopressors to maintain an adequate mean arterial pressure, those generally are the patients that I use corticosteroids on, and the corticosteroid that we use is hydrocortisone, which I know most clinicians tend to use, and the dose is usually 100 milligrams Q8 or some version of that, depending again on how severe the hypotension is. But studies really have been done with a dose up to 400. So anything in that range, less than 400 milligrams per day in divided doses. What is not a good practice is to use very high doses of hydrocortisone. By that, I mean anything that goes beyond 400 milligrams a day of hydrocortisone or its equivalent would not be advisable.
So it sounds like in terms of the dosing, a range of 200 to 400 milligrams of hydrocortisone or equivalent per day in divided doses is probably what would be supported by the current literature. And really the caveat here is not to exceed that 400 because there's probably no benefit and there can be potential harm. Is that correct?
Yes, and we also stipulated a duration. And we know this is certainly very dynamic or fluid. We recommended that the dose, whatever it's used, whether it's 200, 300 per day of hydrocortisone or equivalent, usually hydrocortisone, that be maintained for at least 3 full days at the full dose, and not be tapered rapidly unless the patient is totally off vasopressors, in which case the taper can then ensue. And that is where we felt the literature was more solid in terms of making that recommendation. I've been asked multiple times, what do you do with the patients? Do you really keep them 7 days or 10 days? And that's really a question that clinicians have to look at. Besides the evidence, they have to look at the benefits and harms and cost of keeping patients on steroids. Granted that they are relatively inexpensive, but I think we're more concerned about superinfections, electrolyte issues, hyperglycemia, etc., that can become a problem. And so while steroids might be a good adjunct in shock reversal, steroids have a lot of side effects as well, and so that always has to be balanced. So if one were to use stress dose steroids or steroids for septic shock, it should be used at full dose for at least 3 or more days, depending on how the patient is responding. We don't advocate using high dose and then cutting out only after 1 or 2 days.
So let's just use some scenarios to be very specific for the audience. So what you're saying is that at a minimum, if we initiate corticosteroids, we should probably treat them for 3 days at the full dose. And if after 3 days they are off vasopressors and what we consider to be hemodynamically stable, would it be okay to just stop the corticosteroids at that point?
So there are many clinicians who may be tempted to do that. There is some literature that there sometimes can be a rebound phenomenon when the steroids are abruptly stopped, where there can be rebound inflammation and cytokine release that can make the patient hypotensive again. Again, this is a clinical decision. I think I generally in practice wait until the vasopressors are off for a reasonably good period of time, not cutting out the steroids within a few hours of having gotten off the vasopressors. So whether that's 12 hours or 24 hours, it usually is within that time frame. If I'm going to be stopping the steroids, it usually will be not instantaneous after they come off the pressors.
And you would, and is your practice, and I know that the literature is not definitive here, but based on what you mentioned with the potential rebound, your practice would be that after 3 days as a minimum, once you achieve hemodynamic stability, defined as 12 to 24 hours off vasopressors, you would do a taper. Is that correct?
Yes, or is taper or even really a discontinuation at that point.
Okay, excellent. So let's talk one more question regarding treatment, and where do we stand, Steve, on infusions of hydrocortisone? So let's say we choose the right dose, but instead of giving it in divided doses, we give it in a continuous infusion, and I guess the argument would be that it might help with glycemic control.
Yes, so there are many centers. In fact, in Europe, this is a more common practice than here in the US, where they give the hydrocortisone as a continuous infusion of 10 milligrams an hour. So that's 240 milligrams per day, whereas the practice in the United States tends to be more giving it in intermittent dosing of 100 Q12 or 100 Q8. And it's very common for those of us to see this hyperglycemia spike, within an hour or so after that 100 or 200 doses given. So the claim has been that the continuous infusion does seem to be associated with less of those spikes and provides a better control of blood glucose. And some of the literature on glycemic control also state that, well, it's not like you're not keeping their sugars in a well-controlled range of, let's say, 140 to 180, which we tend to do now compared to, let's say, 10 years ago, but it's how much you're keeping them in that nice range versus the up and down swings, which many have been found to be associated actually with somewhat worse outcomes in some patients because of the erratic way the sugars are getting controlled in patients. And so I think there is literature to support the practice of continuous infusion, although in actual practice, whether it's because of the ease of maybe giving things intermittently rather than worrying about another bag of fluid with medication to hang and administer to patients who may not, tolerate another small amount of volume. I think these are more, I would say, more practical aspects. I think in centers that can do this well with their pharmacists in the ICU, I think the practice can be supported well, and those that prefer to do it intermittently, they just have to realize there are these spikes in glucose levels around the time of those higher dose administration, in which case more use of insulin may be required in those settings.
Excellent. So I think that that's a great clarification, and just gives our clinicians more options to think about. But like you said, it probably depends on what's the ability at each individual ICU to provide one or the other. Let's move on, Steve, to ARDS, and I think that you mentioned that a little bit earlier. That's one of the diseases, obviously, where we've centered a lot of our research regarding the use of corticosteroids, and now maybe the focus is more around CIRCI. But where do we stand today in terms of treating patients with ARDS with corticosteroids?
So I think we have very good to strong evidence that corticosteroids should not be used for the treatment of patients with late ARDS. By that I mean ARDS that develops in patients in the ICU that's, let's say, 2 weeks or beyond. I think where much of the controversy or discussion or debate on rounds and in the literature and in practice is what about those patients where you're contemplating using it early, and how would you define the severity of the ARDS? And so we have more recent definitions from the Berlin conference published in JAMA in 2012. But when we started doing the guidelines, we were still going with what the literature was showing us, and many of the studies for early and late ARDS happen to be at time periods where the previous definitions of the severity of ARDS were still being used. And so when we set out to address this question in patients, again, adult, emphasizing that this was an adult guideline, even our recommendations in sepsis and septic shock really were meant for adults specifically. But for ARDS, particularly those with early and what we would call moderate to severe ARDS, that is a PA-FiO2 ratio less than 200. And within 14 days of onset, I would even maybe qualify that as within the first few days. We suggested, based on moderate quality of evidence, that corticosteroids could be considered for those patients.
So in terms of the way I understand it is, clearly the idea of treating that fibroproliferative or late ARDS stage is not something that's recommended, and that if we are to use corticosteroids in our patients with ARDS, it should be for those who have moderate to severe ARDS as defined by the PaO2-FiO2 ratio, and it should be used in the early phases, correct?
Yes.
Can you mention a little bit more specifics in terms of the dosing and duration that you would use in your practice if you chose to use steroids for ARDS?
Yes. So we recommended that for patients with early ARDS up to day 7 of onset with a PF ratio less than 200, the dose of corticosteroid would be 1 milligram per kilogram per day of methylprednisolone. Notice that methylprednisolone is favored for ARDS as the corticosteroid agent of choice, in contrast to hydrocortisone for patients with refractory septic shock. Methylprednisolone is certainly much more anti-inflammatory, and I think is the most tested agent. It has greater penetration into the lung. It stays in the lung longer. It's the most studied corticosteroid preparation for lung inflammation. So a dose of 1 milligram per kilogram per day in an adult patient with early ARDS, PF ratio less than 200 is what we suggested. And in the setting before day 14, let's say, day 7 to day 13, where you have a situation where the presentation of the ARDS is somewhat early but not too late, then we recommended in those patients who were remaining mechanically ventilated with continuing hypoxemic respiratory failure and ARDS, the dose there is the higher dose, because that's been the dose of 2 milligrams per kilogram per day with slow taper over the next 2 weeks, has been the most studied regimen. And I think we have that information in the digital supplement. I will inform the readers of the article, Sergio, that there is a correction on the forest plots that are in the supplement for ARDS with regards to the mechanical ventilation free days and the mortality and superinfection graphs. We noted this after the online publication came out. The journals are waiting for when the print versions get released to add that erratum, so that anybody referring to the supplement would see the corrected forest plots for the ARDS corticosteroid evidence.
Well, that's good to know, and thanks for sharing that, Steve. So let me just clarify, for ARDS, if you were to start early in a very severe patient at the dose of 1 milligram per kilogram, how long would you treat them?
So most clinicians will generally treat patients for at least several days. Again, the data and the studies are many and using various types of regimens depending on what the cause of the ARDS. Is it community or hospital-acquired pneumonia leading to ARDS? Many of the studies in that particular setting have also used different preparations of steroids. And so I think the best that we could come up with is certainly to keep patients with whatever steroid preparation that they're using. I will just say in my practice, it's usually methylprednisolone, and usually staying with the same dose until there is significant improvement in oxygenation, reduction in inflammation. Some centers will use inflammatory markers to guide that decision, and that the taper should be done slowly and not rapidly because of that rebound phenomenon that can occur in patients whose steroids are stopped rather abruptly. And to understand that using the lower dose of methylprednisolone has not been shown to be associated with a higher incidence of hospital-acquired infection. It has not been associated with a higher risk for GI bleeding or actual bleeding, neuromuscular weakness. It does certainly remains associated with hyperglycemia, but the other side effects or adverse effects of steroids really tend to be more prominent when the corticosteroid doses are in the higher range, at the 2 milligram per kilogram per day range rather than the 1 milligram. So I think the 1 milligram per kilogram per day for early severe ARDS has generally been well tolerated with less side effect profile. And most patients should stay on that same dose until there is significant improvement in oxygenation. That could range from 5 to 7 days. And then slowly tapered over the next week or two after that if they've shown some clinical improvement.
So it seems that a good distinction between treating patients with septic shock and patients with ARDS would be that in ARDS patients, we're using a different choice for corticosteroids, the methylprednisolone, but we're also treating probably for a longer period of time. And because of that, maybe our weaning or our tapering should be also more gradual. Is that correct?
Correct, because the severity of the lung inflammation is such that it's unlikely that if you were to use methylprednisolone, let's say for 3 to 5 days, that you would see a dramatic response. And so these patients generally tend to require a longer period, in which case if you're stopping them during a longer period, you probably should be tapering them to be on the safe side. Whereas if you're using it for shock reversal, if they're no longer in shock, and you're using hydrocortisone and you're trying to discontinue it, stopping it over at day 5 or day 6 really does not have much of an issue, because it's for that shock reversal indication as compared to ARDS, where you need a much longer period of time for really lung inflammation to get attenuated.
Excellent. So I think that in terms of the last population that I have interest, and I know that the guidelines do address this, and this might be a short commentary. What about patients with trauma?
Yeah, here we felt that corticosteroids should not be used in patients with major trauma. However, with that said, the recommendation is again conditional, and we judge the quality of the evidence to be on the low side, and there were issues regarding the trial design, risk of bias, the different doses that were used, and there was just so many types of corticosteroids, different durations, formulations, and imprecision in the pooled results, and we mentioned this in the paper, but it all seemed to point in the direction that corticosteroids were not really associated with a significant enough benefit, and in some patients actually may have caused even harm.
Okay, excellent. Well, I think that, Steve, that this is obviously a topic that, as you mentioned, is very dynamic and still evolving. We'll look forward to new data as these large trials that you mentioned get published, and hopefully we'll be able to have you to come in and give us your commentary and your expertise. One of the things that we try to do also in Critical Matters is tap into the wisdom of our guest and just talk about other aspects that I think are also relevant to the practice of critical care. So if it's okay with you, I'd like to ask you just a couple of rapid fire questions outside of the topic of CIRCI.
Sure.
So is there a book or books that have influenced you the most, or what book have you gifted most often to others?
You know, as I was growing up, I used to read a lot of finance books and management books, thinking that I was going to be an investor.
What happened?
And was going to run a company. I don't know if my uncle in Bayside, Queens, New York, may have had that influence, because he was always looking at his stocks, and he sort of like was giving me financial advice. So I ended up reading a lot of finance books. As I was getting older, I began to venture mostly into spy novel kind of books. But more recently, I was at a burnout summit of the Critical Care Societies Collaborative, and one of the invited guests there is a self-described medical musician, Sergio.
Okay.
And he gave me a book. His name is Andrew Schulman.
Okay.
And he has a bestseller. I've started to read it. I haven't finished the whole book. I don't know if you've heard about it. It's called Waking the Spirit.
I have not heard about it, but it sounds interesting.
Yes, this was a patient who had what was thought initially coming into surgery, thought that he had pancreatic cancer and they were going to do a Whipple procedure. Luckily for him, it wasn't a cancer, but nevertheless, he developed postoperative complications and actually had a cardiac arrest and post-op, and basically was in the surgical ICU here in New York City. And the bottom line is he survived that episode, and one of the tools that he really subscribes to have turned his life around and made him get better was the introduction of music into his ears, which his wife kind of insisted that the clinicians do. This was at a time when, we thought that giving headphones and playing music in a patient that's resting and sedated and whatnot, may not necessarily be a good idea. Well, he felt that really helped him, because as that music was being played in his ears, the book seems to suggest, and his surgical intensivist, which also helped him write the book, tells us like all his vital signs started improving. His lactate, which started at 17, fell, and the bottom line is he got better. And so I'm reading through this, and I think it's a very inspiring book.
Waking
so
the
far.
Spirit, absolutely. So we'll share that with people. It sounds very interesting read. So going along, is there something that you believe either in life or in critical care to be true that most people don't believe?
One of the things that I think sometimes is like, people can assume, or even patients and their family members can assume, that a patient is well, looks well, but at the same time really can be very, very sick. And I think we learn that every day in our practice when we confront, a patient or a family member of a patient who's very sick in the ICU, and they're really just wondering how sick the patient is. And he looks so well last week or the other day, and how can he be so sick? And now you're telling me he's dying in the ICU. And so sometimes navigating through that, where you could look well, but can be very sick inside. And I think we all have to sometimes, stop and reflect at that, and that can actually happen. That you could be very, you could look well, but actually be sick, and that applies to us. as well as to patients that we care for.
And I think that that's a great point. And once somebody told me when I was training that sometimes the most difficult task is to identify who's sick and who's not. And I think it kind of falls in that realm that even critical care physicians sometimes can be fooled, but also, I mean, as family members, that is something that I think is sometimes very difficult to navigate.
Mm-hmm. And we try to teach this to our fellows.
Absolutely. And the last question, and I want to be very respectful of your time, but the last question is there anything that you would want every intensivist or every sound critical care intensivist who's going to listen to this to know?
Yes, I think, we as intensivists, we like numbers, we like to reverse abnormal physiology, we like to do procedures and try to apply our knowledge of various techniques. But I think, and that's certainly great and noble to do. But I think for some patients who clearly are not responding to what we would expect for the amount of aggressive interventions that we're doing to them, that we realize and reflect that maybe there comes a point where we just have to realize our limitations, and that as much as science has advanced in some of the things that we do, there are just some patients that simply are not getting help, and we should know when that time point comes and switch gears and go more into the compassionate palliative side of things and know our limits. And I think, when I was younger, I was so much I went into critical care with the mindset of reversing abnormal physiology and doing procedures, and I realized, 25 plus years later that, there were times I would have been more aggressive if this was 25 years ago, but now I know my limits, and I know when it's time to shift gears from being, a doctor that can treat critical illness to a doctor that maybe should be more compassionate and realize that this patient is dying and better end of life, rather than my intensivist skills of doing procedures is what this patient needs.
And I think it's a great place to stop, because I think it's a very powerful message, and it's a message that I've heard with other of our guests as well. And I think very well said. Steve, I want to thank you enormously for the generosity with your time and your expertise. I definitely look forward to having you back when we have more data to discuss, but also I know that there are many other topics that you're passionate about and you can tell us a lot about. So hopefully we'll have you back. Thank you very much for being our guest.
My pleasure, and thank you all for listening.
Thanks again for listening to Critical Matters. Make sure to subscribe to this podcast on iTunes or Google Play.